All right. Our moderator today will be Dr. Rhonda Holliday. We're so grateful that you joined us for this presentation. Dr. Holliday.
Good afternoon, everyone, and welcome to our NCPCR Learning Series, Demystifying Long COVID, the NIH Recover Initiative. Before we begin, I just want to do a few housekeeping rules. We will have Q&A at the end of the presentation. However, if you have questions that arise during the presentation, please use the Q&A feature. At the end of the session, during the Q&A, you may also unmute yourself to ask questions as well. We also ask that you complete an evaluation, and the link to that evaluation will be posted in the chat. So without further ado, it is my pleasure to introduce our guest speaker today, Dr. Ego Ofoltakon. Dr. Ofoltakon is the Grady Distinguished Professor of Medicine at Emory University School of Medicine and Professor of Behavioral Science and Health Education at Emory University Rollins School of Public Health. He is a staff physician at Grady Memorial Health System, the Associate Dean for Research Development, Emory School of Medicine, the Associate Division Director for Research Infectious Disease Division, and the co-director of the Emory Center for AIDS Research Clinical Core. His career is devoted to combating the long-term sequelae of HIV, particularly among underrepresented populations. His work has focused on the threat that age-related comorbidities pose to healthy aging in persons with HIV. Drawing on his HIV experience, he leads the Atlanta hub of the NIH initiative, Researching COVID to Enhance Recovery, also known as RECOVER, aimed at understanding the long-term post-acute sequelae of COVID-19. He serves as the national chair of the RECOVER Adult Cohort Coordinating Committee that oversees the governance of the adult cohort, one of the largest of such cohorts in the world. Dr. Ofoltakon, I will turn it over to you, and thank you.
Thank you so much, Dr. Holliday, for the kind introduction. And I want to express my profound appreciation for the organizing committee for inviting me to share with this group. So what I hope to do today is to give you an update of the effort of the federal government, that is your effort, the public effort, to help us understand this whole new emerging post-acute sequelae of an infectious diseases, SARS-CoV-2 infections. I've titled my presentation, Demystifying the Long COVID, the NIH initiative. So these are my objectives, to kind of review very briefly the current state of where we are with the science of long COVID, where is the field, and then to provide you the progress that has been made by the RECOVER effort. RECOVER stands for Researching COVID to Enhance Recovery. The progress in the definition of post-acute sequelae of SARS-CoV-2 infection, which is now known as long COVID, quantifying the burden and identifying some of the risk factor, and some of the things that are in the pipeline, things that we're doing to really not only understand, improve our understanding of long COVID or post-acute sequelae of SARS-CoV-2 infection. What are we doing to diagnose it and also to treat these conditions? I just wanted to highlight that I started my career as an HIV researcher, studying the long-term sequelae of HIV among women and vulnerable population. And I've been here at Emory and at Grady for over 20 years doing this work. And a lot of the lessons that we learn in our work in HIV is what we're translating today to help us understand long COVID. Many of you may have heard the term brain fog. And when we talk about long COVID, that is sometimes the way all of us feel. A lot of brain fog, because to different people, the term long COVID means different thing. We don't have a uniform definition. We don't have a way of diagnosing it. We don't even have a standard treatment. It's kind of really foggy. It's out there. When you talk to people, you talk to CDC, they have their own definition. You talk to NIH, they have their own definition. You talk to WHO, they have their own definition. If you read the New England Journal of Medicine, Cells or Nature, you have a different definition. If you read the New York Times, or you read AJC, it's all completely different thing. Really, it's something that it's out there. We know there's something wrong, but we really don't have our hands around it. So this was what was happening shortly after the epidemic started in 2020. Towards the end of 2020, we knew a lot of people died, but we also knew a lot of people recovered. It became obvious that people who were recovering from the acute episode of long COVID, they were not returning back to normal health. So that was when some people came together and said, look, I got out of, I am lucky to not die from my COVID infection. I was in the ICU, I was admitted, now I come back, my life is never the same again. Or I just had a mild infection, and a young woman who is in their 30s with 2 kids who used to go running, 3 or 4 miles a day, suddenly had a mild case of COVID, and after then, suddenly discovered that life was never the same again. They can't sleep well, they can't exercise, there's no really appetite or zest for life the way they used to be. And so people began to recognize this towards the end of 2020, and then a group came together and started talking to one another, and then there was advocacy. And I think at this time also, one of the senators, Senator Tim Kaine of Virginia, developed COVID and also developed aftermath, long COVID, and Congress listened. And towards the end of 2020 and early part of 2021, they released a huge amount of money to the NIH to begin to look into this condition. Many of you can recognize Dr. Gary Gibbons, who used to be at Morehouse, and now the director of NHLBI, announcing this initiative at the beginning of 2021. So with this initiative, this big consortium was started called RECOVER. Like I said, RECOVER stands for Researching COVID to Enhance Recovery. A huge application that involved almost every institution across the country. And then by the summer of 2021, the team that would really study this condition was assembled. So the team include what we call the hub, the clinical hubs, and then that was responsible for the longitudinal cohort. Then you also had the electronic health record team. Then you have the autopsy or the pathobiology, tissue biology team. Then the clinical trial teams, and then there were also several smaller pathobiology studies. So in addition to the elements that include the hubs and the cohorts, there were also cores that were responsible for supporting the cores and the hubs that were recruiting participants. So we have the clinical science core at NYU, the data resource core at Harvard, BIOS repositories core at Mayo, and then you have the clinical trial data coordinating center at Duke. So these are the hubs for the adult cohort across the nation. These are the various institutions that are involved. And these are some of the PIs of the hub from across the country. Here in Atlanta, our hub included almost all the major academic institutions in the city or healthcare in the city. We have Hope Clinic, which is a part of Emory. We have the Atlanta VA. We have Morehouse School of Medicine. We have Emory at Grady and KP, Georgia. And these are the PIs of the different sites. Priscilla Pemo from Morehouse leads the site at Morehouse. Shushma Cribb and Vince McConey lead VA site, and then we have Tiffany Walker and Jenny Horn leading the Emory and Grady site, and Zantia Wiley leading the Hope Clinic site, and we have Jen Ganda, who recently left, was in charge of the Kaiser Permanente. So enrollment into the study started on October 2021, and by October 2023, all of the adult cohort were fully enrolled. And so what I just wanted to spend the next 3 or 4 minutes on is what have we really learned. So when we started recover effort, there was so many uncertainty about this disease. Like I said earlier on, we didn't have a uniform name. Different people call it different things. Some call it PASC, some call it long COVID, some call it different things. There was no standard definition, and there's still no standard definition. How do you recognize what is the ICD code for long COVID? We didn't have. The time frame from disease onset was uncertain. So how long after you recover from your acute COVID do you develop a long COVID? We don't know. And is long COVID a homogeneous or heterogeneous condition? Is it a disease, one single disease, or is it different diseases that manifest in different ways? The symptoms and clinical findings were not well characterized, and we definitely don't understand the pathophysiology. So what have we learned so far? So what do we know now? One, a few things. We do understand, even though we don't really have a name, a definition for it yet, there are common symptoms. I mean, there's a kind of a general agreement on what the common symptoms are. So this was a study that was done towards the end of 2021. It was it included almost 50,000 adults from age 17 to 87, and they looked at, these were people who have recovered from acute COVID, and they look at different symptoms, every organ system as well as lab abnormalities. And they were able to characterize the 5 most common symptoms in this study. And this study was really a global study. North America, South and Central America, Europe, Asia, some part of Africa were included in this study. The 5 most common symptoms, this was during the beginning, early part of COVID, 2020-2021, were fatigue, headache, attention disorder, hair loss, and dyspnea. But what is impressive about this study, though, was that at least 80% of all the people that were examined, of the 47,910 people that were included in this study, 80% of them had at least one symptoms. It doesn't mean that 80% had long COVID, but at least the virus left their mark on at least 80% of the people. And almost every organ system that you looked at, there was some abnormality, either in terms of symptoms or lab abnormality. The other thing we now know is that these symptoms are not made up. We see that they have abnormal pathologic findings. So in addition to having chest pain, when you look closely at the heart of some of these people through autopsy, you see myocardial infarction. You see evidence of a neuroinflammation. You see evidence of endothelial dysfunction in the blood vessel, microangiopathy. In reproductive organ, you see reduced sperm count, for example, in male. You see gut dysbiosis. There are evidence of viral persistence and viral reservoir within the gut. And so in the lungs, people complain of cough, shortness of breath, but in some people, you actually see abnormal gaseous exchange, suggesting that these symptoms are not made up. They are associated with clear pathologic abnormalities. The other thing we now know is that it's not a single entity. It's not just one disease. There are different subtypes. So this is data from recovery. This is from the electronic health record, one of the largest electronic health data that has ever been put together for any disease in the world. And they looked at the different symptoms cluster. And they find that there are 6 different symptoms cluster: multi-system disease plus lab, pulmonary cluster, neuropsychiatric cluster, cardiovascular cluster, pain and fatigue, and multi-system disease with pain. So the other point is really, we don't really understand the full health implication as well as the economic impact yet. but we think it's going to be huge given the size of the pandemic. Almost everybody worldwide had COVID. Very few people today can say they have not had COVID. So if even 1% of people develop long COVID, that is still a huge amount of people. So we think that the impact of this is going to be huge. And this is again data from CDC MMW from August of last year. What they did was they looked at the impact of long COVID on activity of daily living, how long COVID limits activity. And they found out that, across different age groups, at least 25 to 30% of people claim that their long COVID had limitation on their activities, of daily living. And then the data from the National Vital Statistics, which is again an arm of CDC, showed that during the first half of early part of the pandemic, at least 3,000 to 4,000 people died from complication of long COVID. So this is something we're still trying to understand what is going to be the impact of this. Maybe people may not die, but it could affect people's quality of life, ability to go back to work, ability to go to school, ability to concentrate. So we think this is going to have huge impact. The other thing is the trajectory of disease. Is the disease going away? This is another study from France, and they have this large national database, and they were able to follow a group of people, about 1,000 of them, and they were actually able to use validated survey to follow them on a day-to-day basis. And they asked the question, what symptoms do you have? How does the symptom affect your quality of life? And they tracked them on a daily basis for almost a period of 360 days. And what they found out was that in a significant proportion of people, up to 80% of people, the symptoms they started with persisted all through the year. Not only did the symptom persist, they also found that the symptom affected their quality of life, personal activity, professional activities, social activities, morale, family life, relationship with caregiver. And they thought that disease was, this was an unacceptable disease state, something they don't really want to live in, suggesting that this is not going away. We're likely to be in this for a long haul. What we know about the pathophysiology, this is area that is, people are doing a lot of work in. There are a lot of speculation that the reason why people have long COVID is because some people are not able to clear the virus, that the virus causes immune dysregulations, serotonin release, mitochondrial dysfunction, autoimmune disorder, low cortisol level, damage to the endothelium of the blood vessels, and clotting disorder, dysbiosis, and vagus nerve dysfunction. So these are all mechanisms that is being investigated. And we can't really find a true treatment for this condition unless we understand the pathobiology. So it's an area of a huge study. So what are the gaps in the literature? Many of the studies so far till today have been really retrospective study. Many of them are based on electronic health record or electronic cohort. Most of the studies really study populations that are not impacted as much by long COVID. Reliance on self-report, relatively small sample size. Some of the studies were single site or limited multiple sites. Many have limited follow-up period. And of course, like we said, there's no consistent definition. Everybody uses the definition they want to use. So this was really what Recover was set out to do, to fill this gap. So the specific aim of the Recover study was to characterize the incidence and the prevalence of long COVID, to characterize the clinical cause of disease. Do people recover? Do people continue to be sick? How long do they continue to be sick? And then to define the pathophysiology or the biologic mechanism, because if we know the pathophysiology, if we know why people have long COVID, then we can actually figure out a way to treat the condition. What this means in lay terms is that how many people are getting long COVID, why do some get it, why others don't, what are the symptoms, how long do people get sick, why do people get long COVID, again, to be able to come up with a way to diagnose it, determine the severity of disease, and provide and figure out an effective prevention and treatment measure. So what have we done so far in Recover? So this is the design of the study. So this was published, one of our publications in PLOS One towards the middle of 2023. So what we did was that we recruited people with a COVID infection and then control that COVID infection. So both infected and uninfected. And the infected group were recruited in two phases. The acute phase, which means within 30 days of acquiring the infection, and then the post-acute phase within after 30 days post the acute episode. So we describe the study as an ambidirectional longitudinal study. That means people were followed both prospectively, and we also collected data retrospectively from participants. So what that means, for example, if somebody were to be enrolled in the study today, April 23rd of 2024, and they had their COVID in April of last year, they will be entering the study at 12 months, and then we'll collect their 1 year data retrospectively 12 months back and continue to follow them until they reach month 48. And so the symptoms, so the procedure really includes what we call symptom-triggered tiering of study procedure. So there's tier 1, which includes survey, lab, biospecimen, minimal exam that everybody participated in. And then based on symptoms, people go either to tier 3, tier 2, or tier 3. So 30% of the original population go to tier 2, and then another 20% goes to tier 3. These are some of the tier 1 procedures. So like I said, questionnaire, demographic information, social determinants, medical history, COVID history, vaccination status, substance use, symptoms, screening. And then you have minimal exam, physical exam like vital sign, waist circumference, seat to stand, active standing test, and then you have the laboratory studies and biospecimen, collected blood, saliva, urine, stool, and nasal swabs. And these are some of the lab tests that were done, just simple comprehensive metabolic panel, CBC, lipid profile, hemoglobin A1C, coagulation profile, on and on and on. And so these are the symptoms. So symptom screener was very detailed. All 12 systems were reviewed and 44 symptoms were elicited, very detailed, and this had become a very useful tool. These are some of the biospecimens that were collected. Like I said, nasal swab was collected, blood was collected in CPT, sodium citrate, EDTA, SST, PAX gene, RNA-Q, and then urine, saliva, and stool. So during the first year, samples were collected at baseline 3 months, 6 months, and 12 months. And after the first year, samples were collected once every year. So these are some of the tier 2 procedure. Again, more advanced lab, more advanced clinical assessment, and then some radiologic study, including a chest CT, fibroscan, ultrasound, and echocardiogram. And then tier 3 procedure were more advanced. So more sophisticated lab, including B12 and methyl melanolic acid. Then we collected some blood that will be done at the central labs. And then clinical procedures such as nerve conduction tests, EMG, skin biopsy, muscle biopsy, lumbar puncture, and then radiologic studies, including brain MRI, cardiac MRI, and then other clinical assessments such as audiometry, endopad, and complete eye exams. So by the end of October of 2023, we completed the recruitment. We recruited 14,799, almost 15,000 people. About half of them were infected, were recruited at the post-acute phase, 34% in the acute phase. And then we had about 17% were infected control. So these were the sites. It's 3 sites across the country, including Puerto Rico and DC, 83 sites from 33 states. And so this is the demographic of the study population side by side with the demography of the United States. One thing that I just wanted to highlight is that you can see that it's a representative cohort. Black and Hispanic and are almost represented at the same proportion that they are represented in the general population. So these are some tables of some of the procedures and tests that we have done, just to let you know that we've done quite a lot. EKG, vision test, ACTH, cortisol level, 6 minutes walk, a lot of NIH toolbox, mini EKG, oral glucose test, fibroscan. So, and these are some of the biospecimens that have been collected, are tons and tons of biospecimens. So, in a snapshot of the study is that 33 states, 83 sites, 15,000 participants, over 6,000 common data elements, over 120 million data points. A snapshot of the startup study cohort. It's one of the largest and the most comprehensive of its type. It's a representative pan-US prospective cohort, inclusive of the population that is most impacted. So we're really now in a position to be able to begin to answer some of the key questions, not only for the general population, but also to be able to look at special population, Black and brown, men and women, rural, non-rural, older and younger people, to be able to see how long COVID really affect different demographics. So what are we doing with this data? So the first challenge is really, how do we define long COVID? So this was our first paper in JAMA last year. And so it was a stepwise approach. So, so first of all, we wanted to start out with using the symptoms. So can we really recognize long COVID by symptoms alone? So if we can do this, it will be easy because anybody can elicit symptoms. If you don't need to do any very special tests, then if it's just symptoms, you can elicit symptoms in Atlanta, you can elicit symptoms in Macon, you can elicit symptoms in Timbuktu. So that would be a very easy way. So the first part was actually to use the symptoms that we have collected to see if we can actually define long COVID. And then to then add, augment whatever definition we get, however sensitive the definition we have with symptoms, to then augment it by integrating multiple additional data modalities. So such as the lab value, other syndrome, cytokines, and other special lab. And then apply it to investigate the mechanism of disease, characterize the phenotype, evaluate the potential risk factor, develop and evaluate intervention, and then continue to refine the definition until we have a very sensitive way of defining it. But this turns out not to be as simple as it is. Usually, I'm an infectious disease physician. If you want to define a disease condition, usually you have like a gold standard, a test. You know, you take a tissue or you take a blood culture or you look at the microscope and you say, people who have this disease, they have this condition. And then you look at the symptoms that people with those kind of pathognomonic condition have. But here, we don't really have a gold standard. We don't have a way. We don't have a PCR. We don't have a blood culture. We don't have an ELISA way of testing for long COVID. All we have is a group of people out there, a general population where some people have COVID, others don't. And among those who have COVID, some of them are going to develop a long COVID. And then we have the study of 15,000 people that we have observed, and we know those who have long COVID among those who were infected with COVID. So we went about doing this in a stepwise manner. First of all, what are the symptoms that you see that are more common in people with a long COVID and those who don't have long COVID? And then when you get those pool of symptoms together, then you shrink it down to the list of past defining symptoms and then assign a score to each of those symptoms based on model field and determine the optimal score threshold for identifying long COVID. So that is what we did. So step one is that, remember we said we collected 44 symptoms. So of those 44 symptoms, we set the odd ratio at greater or equals to 1.5, and we said, what are those symptoms that are present in those people who have had COVID infection and the control? And we were able to identify 37 symptoms that are shown on this slide. You can review this in detail if you look at the paper in JAMA. And then the second thing we then did was to define those symptoms, narrow the symptoms down using this statistical approach called the least absolute shrinkage selection operation, or LASSO. Is a form of logistic regression with balancing of weight. Based on that, we were able to identify these 13 symptoms that are most likely to be associated with long COVID. And then based on the model fit, we were able to provide score based on their weighted model fit, provide score for each of these symptoms. So for example, And then if somebody has 2 or 3 symptoms, we can then calculate a score, a long COVID score for that person. So for example, if someone has post-exertional malaise, brain fog, fatigue, dizziness, the PASS score would then be 7 plus 3 plus 1 plus 1 plus 1, which will be equal to 12. So we can now take somebody who comes to your clinic and say, oh yeah, I have brain fog, I have shortness of breath, and I have cough. Those are my 3 symptoms. And then you can now give those assigned score to those symptoms and then define the severity of that disease based on the score. And then using tenfold cross-validation and optimal score threshold for PASS, we were able to define the optimum threshold, that will define somebody to say they truly have a PASS. And using this approach, we identify a score of 12 to be the optimum threshold. So what that means is that if you come in and you have a series of symptoms and we calculate the score and your score is equal to 12 or more, that definitely means you have a long COVID. But if your score is less than 12, it does not rule out long COVID. So that is really the downside of this approach, but at least it's the beginning, the first step towards finding the definition. Now we can identify a group of people with a high degree of certainty that these people actually have long COVID. But the other pool, we cannot say they don't, because there are people that may have a single organ symptoms that may qualify them for long COVID, but they are not able to reach the score threshold. So we're still working on that, but at least now we have some form of objective definition. So using these symptoms, we were able to estimate the prevalence of PASS for long COVID within the population, the 15,000 people that we studied, to be around 10%. We're also able to show that PASS positivity was more common and associated with more with the earlier part. People had a pre-Omicron during the early phase of the pandemic. People had the original strain of the virus, and then vaccination was protective. And then the more infection you have, the higher the likelihood of developing long COVID. And then long-term symptoms associated with SARS-CoV-2 infection span across multiple organs. This is not a disease of one organ. Almost every organ in the body can be infected. And we were able to show some of if you have long COVID, what are the symptoms that are most likely to occur? And what is the frequency by which those symptoms will occur? Almost everybody, 87% of people had what the post-exertional malaise. 85% had fatigue, 64% had brain fog. So these are some of the common symptoms. And the other thing we were able to show was that there was also clustering. It's not a homogeneous disease condition. There are different clusters, and we were able to identify 4 different clusters within this observational cohort study. So what is the next step? So the next step now is to augment. We now have a definition based on symptoms. So can we improve the sensitivity of those of the text of the score? So that is what we're now doing to integrate more additional data point, either syndrome, other symptoms, biomarkers, lab abnormality, to improve the sensitivity of this test. So this is kind of the next phase. And to do that, we have to generate tons of more data. So one of the things that the Recover is going to do, it's, from the 30 to 15,000, we have 15,000 adult patients. There's another study of pediatric patients, which also have another 15,000. So from this 30,000 cohort, we're going to do multi-omic profiling, including microbiome, metabolomic, plasma proteomic, transcriptomic, epigenetics, and GWAS. And so this would help us to begin to do a number of things. First, identify molecular associated with PASS and subtypes, identify mechanism of resolution, identify the mechanism of development, identify individuals with unrecognized risk or uncharacterized phenotype, identify the protective variants for PASS, and also identify potential mechanism for protection. And some of these data will be plowed into defining of improving the definition of PASS based on the score that we have developed. The other thing is the recovery. There's a lot of pathobiology study, I think about 44 of them across the country that are looking at different aspects of this condition, looking at all types of immune correlates. And all of these are going to feed in data that will be used to continue to refine our understanding, our definition. Hopefully one day we'll be able to find a target for treatment. I just wanted to highlight this. This is Rafik Sakali, who I work with here at Emory, who is actually looking at metabolic and epigenetic mechanism of PASS. This is another collaboration we have with ophthalmologists, University of Nebraska, UCSF here at Emory, and then Kamara Adamski, who is a medical student that is working with me, looking at the eye as a site of viral persistence, and also using microvascular damages as associated with the eye as really a proxy for diagnosis of lung COVID. And there's a group at Emory who is, this is just a proposal. Hopefully we move forward looking at artificial intelligence. So that we've done, remember I said we did brain MRI, CT scan, of the liver, of the lung, and hoping that they can see using artificial intelligence can help us identify some imaging findings associated with lung COVID. So there are a series of clinical trials that are ongoing now, 5 of them to be specific, based on viral persistence, cognitive dysfunction, autonomic dysfunction, sleep disturbances, and exercise intolerance, and then fatigue. So one of the ones that is kind of almost halfway done is a vital study, Recover Vital study. The premise of this study is that there is viral persistence. People who develop long COVID is because they have the body was not able to clear the virus. There's some virus hiding in the sanctuary site, whether it's the brain, the gut, the liver, wherever it is. And so that if you give additional, if you treat them with Paxlovid, which is the antiviral drug that is used for treating long COVID, give them a longer course of Paxlovid, you might clear the virus, and their long COVID would improve. So there are 3 arms. One is going to do 25 days of Paxlovid, another 15 days, and then placebo. And then you have the Neuro Recover study, which is looking at different interventions. Many of them are really non-pharmacologic intervention to improve the brain fog that is associated with long COVID. Then there's the autonomic dysfunction that is using IVIG, as well as a drug called ivabradine, a drug that is used to decrease heart rate, and then some non-pharmacologic manipulation to improve autonomic dysfunction associated with long COVID. So the sleep study is studying a drug called solriamfetol and medavinil, which are used for daytime excessive sleepiness, melatonin, as well as light therapy to improve sleep disturbances associated with long COVID. And then there's the Recover Energize, which is really dealing with exercise intolerance. It's really focused on personalized cardiopulmonary rehabilitation, structured pacing of activities to really see if this can improve long COVID. This is just to show some of the publications that have come from the effort so far, 8 publications, mostly from the electronic health record. We talked about the JAMA paper. We have 68 paper in preparation, 15 in review, and 5 was recently accepted. And we're working on a number of other manuscripts that will describe the trajectory of long COVID over time, the change of impact of long COVID on changing work status, impact of race, ethnicity, health disparity, rurality on the risk of long COVID, vaccination and reinfection, and long COVID in immunocompromised individuals, including persons living with HIV. This is just to say that the effort was recently received a recent, I think 2 or 3 months ago, NIH added additional $550 million to the original $1.12 million to continue the study through 2026. And we are putting together a distributive biostatistical node to help expand our analytic capacity so that we can rapidly continue to publish our work. So now we finished recruitment, we are implementing the protocol, we are focusing on retention, and then, like I said, we're trying to improve the definition of PASC based on the symptoms score that we have developed. And we're looking at papers that are looking at manifestation of long COVID across the lifespan. Pediatric paper, I think, is in review. Pregnancy paper is almost done. Aging paper, impact of long COVID on aging population is in development. So the point here is that the recover infrastructure, it's a public infrastructure. It's available to anybody, people in Morehouse, Emory, any researcher across the country is welcome to leverage the resources of the infrastructure. It's a publicly funded infrastructure. The data, the specimen are all available, and we want to encourage all of you to use the resources if you're interested in the science of long COVID. So Recover has developed one of the most elaborate infrastructure to study long COVID. It's the largest and the most comprehensive prospective study of its kind, robust, curated biospecimen linked with elaborate amount of data. And like I said, it's available to everybody. The study design is pragmatic, and the enrolled population is representative of the population of the US. And we're now beginning to make sense of the data and to provide an objective definition of long COVID with reasonable degree of precision. So with that, I just wanted again, thank you for inviting me. I want to acknowledge all the participants, 15,000 participants, I think 930 of them from Atlanta here, including Morehouse, Grady, Emory, Kaiser Permanente, Atlanta VA, NIH, especially the NHLBI, Gary Gibbon and his team who are actively involved in this study, and then the various institutions across the country that are involved with this effort. Again, thank you for inviting me, and I will stop here.
Okay, thank you, Dr. For that very enlightening presentation on long COVID. We have two questions in the chat. So I will read the first one, and it says, you may have answered this one, but I'll read it. Can you share how the Emory Recover team is assessing and evaluating post-exertional malaise, one of the hallmark symptoms of long COVID?
So one of the things, so like I said, it's very elaborate. The study is very extensive, extremely very elaborate. The study, we have what we call the symptom screener that includes 44 different symptoms. And so people come in, it takes almost 4 hours for you to go through the different surveys, and then there are different validated tools that we're using to capture symptoms. So that is one. And then once people are identified with specific symptoms, depending on the type of symptoms they have, they actually have opportunity to do additional tests. So we do echocardiogram, we do pulmonary function tests, we will be doing right heart catheterization. There is endopart. So these are all different objective measures. So in addition to the subjective assessment that we get from the symptom screener, there's also opportunity. And then we also do what we call a cardiopulmonary exercise test, the CPET test, to really get to the bottom of post-exertional malaise.
All right, thank you. The next question that we have from the audience is, given that an estimated 50% of people living with long COVID meet the criteria for ME/CFS, how are you building on the research that has already been done in that field? And how are you making sure that you are including other infection-associated chronic conditions in your studies?
Well, thank you so much. That is a very important question. There's a group of investigators within Recover who have expertise in NECSF. And so they are actually trying to use both the symptoms, the procedures, and the various tests that have been done to try to define what proportion of long COVID patients within recover actually meet the criteria for NACSF. I know there's a paper that has been done, written, and I think it's undergoing review to really quantify the overlap of long COVID or the proportion of people with long COVID that have the NACSF phenotype. And in addition to that, we are collecting a lot of biospecimens, remember blood, and very soon we will start doing lumbar puncture to look at some of those biomarkers of NACSF. So the focus of recover is post-acute sequelae of infection resulting from SARS-CoV-2 infection. So that is really the focus of recover. But we do think that the effort will also inform the post-acute sequelae of other infectious diseases. So we don't think this is limited to SARS-CoV-2 virus alone, that there is other viruses, West Nile, EBV, many other infections that could actually elicit this type of phenomenon or illness. The reason SARS-CoV-2 has become a focus of study is because of the proportion. Almost everybody, in the world. You have to look really hard to find somebody that has not had a long COVID infection. So almost everybody is affected. Even if only just a small proportion of those have long COVID, it's going to be a huge proportion. But I think the data that is coming out of long COVID is going to inform post-acute sequelae of other infectious diseases.
Okay. Great. And I do see we do actually have a couple of questions in the chat as well. So the first one is what role does the vaccine play in long COVID? So how much of an effect the vaccine has in terms of long COVID?
Well, what our data has shown, our publication in JAMA, and I think data from other groups have shown, is that the less severe the acute infection, the less the likelihood of long COVID. So if your acute infection is not very serious, then the risk of developing long COVID is reduced. And we find out, and I think I presented it in one of the slides, that people who have been vaccinated have slightly reduced risk of developing long COVID. So the risk is not zero, but it seems like vaccination offers some degree of protection.
All right. And then how long does long COVID, or how long will long COVID persist? And do you think that the severity of viral load plays a role in determining the time frame of long COVID?
That is a great question, and that is a question we're now still trying to understand. We do have a paper now looking at what we call the trajectory of long COVID that will look at how long COVID is. So since we have these 15,000 people that were prospectively followed, for several of them, we actually knew when they developed their long COVID. So we now have opportunity to look at when their symptoms started, how long their symptom lasted. But one of the data that I presented from the French group, they had almost 1,000 people that they followed every day for 360 days. And they looked at the symptoms and they looked at the impact of the symptoms on their quality of lives. And what they found out was that for 80% of all the people they followed, symptoms persisted for the 360 days that they looked at. And the symptom was severe enough to affect the quality of life. And so some people think that we are in this for the long run, and it's not going. So this is an emerging data. It's something that we're still studying, but it does seem anecdotally that it seems like the symptoms fluctuate, but for some people, it doesn't completely go away.
Okay. And the other question that I see in the chat is, how is this study different from other viral impacts?
So this is what one of the beauty of this study. So first of all, this is the first time in the history of science that we actually have the opportunity to study post-acute sequelae of an infection. And this is the largest of its type. And so we will have the opportunity to really understand what happens after an acute infection in these 15,000 people that were enrolled in recovery. And like what I said earlier on is that I don't think this phenomenon is unique to SARS-CoV-2 virus, that other viruses do cause this type of phenomenon, and that the finding from this study will help inform the way we study post-acute sequelae of other viruses like EPV, West Nile virus, CMV virus, dengue fever, on and on and on and on.
Okay. So we just had another question to come in.
Mhm.
Is anyone looking at viral load PCR serum tests similar to HCV or HIV and the correlation to long COVID?
Yes. The simple answer to that is yes. We are, so the hypothesis is one, people have long COVID because they have persistence of the virus, the SARS-CoV-2 virus itself. The other hypothesis is that there are dormant viruses that lay dormant in the body, and that following the acute infection, these viruses are activated, like EBV, like CMV, and other viruses may be activated. And we also think that in immunocompromised patients like HIV, that there might be interaction between the immune impact of long COVID and the immune impact of the chronic HIV infection. So these are all speculation, but we've collected data to be able to definitively answer some of those questions. So stay tuned.
Okay. I think we have time for maybe one more question. We're done with the questions in the chat, but if anyone wants to unmute themselves to ask another question, we do have time for about one more question.
Hi, my name is Alba Zola. I'm a physiatrist that takes care of long COVID patients. And I just posted my question because I think we spoke a little bit about the definition paper from Recover and the PASS score and its intended use. We are implementing the PASS score as a way to strengthen our cohort and our ability to identify these patients for research. But my understanding was that there was a big argument against using it in clinical practice. So I think that you had mentioned that. So I just wanted to clarify, because, for example, for determination of each one of the symptoms, there are specific questionnaires and specific ways of asking about those symptoms to determine their presence. So, is it something that we're trying to push as a clinical tool, or is this still not ready for prime time?
Well, the answer is not ready for prime time. So it's the beginning of the definition. And so what we're now trying to do is to refine the definition, the score, to make it more sensitive. What we can say for sure, if the score says you have long COVID, you truly have long COVID. But if the score says you don't have long COVID, we can't say you don't truly have long COVID. So we classify those as indeterminate. So what we want to be able to do at some point is to have a score that is able to rule in everybody with high degree of precision. And so remember, the score is based on symptoms. So we're not going to be adding labs. We're not going to be adding biomarkers. We're not going to be adding other syndrome. We're going to continue to fine tune it until we are able to come up with a definition and a score that can capture the entire spectrum of long COVID.
Okay. Dr. Fulton, I know that you have another engagement, but do you have time for one more question?
I can take one more.
Okay. So I see a hand raised, Zuri Dale, if you can come off mute and ask your question. You're still on mute.
Thank you. Hi, my name is Zuri Dale. I am with Texas Southern University. I do appreciate this. I've done a lot of work on long COVID and COVID-19 over the past 3 to 4 years. So a lot of the information presented was not necessarily new to me, but I do have some observations. And I'm familiar with your study, the one with the approximately 15,000 individuals. And so one of the questions I was going to have, and you made a note about it, about how, with that particular study, the proportion of minority populations was low, but it was comparable to their representation, in the United States. But I think one thing that your study did was underscored how representation can lead to data that is somewhat misleading in a sense of the the number of people who are diagnosed with long COVID being lower and being a underrepresentation of the true number of people in that minority group that have COVID-19. And in your particular study, we saw that for Hispanic individuals and for African Americans. And so my question is, how do we increase the number of minorities that participate? Because participation in clinical trials and in the research is ultimately the goal. But what we are seeing is that the data and the studies overwhelmingly represent Caucasians and Caucasian women in particular. So it leads us to believe that individuals who are most impacted by COVID-19 are not also impacted by long COVID. And as we continue to develop a definition and also statistical ways to assess these relationships, how do we do that? What are some of your suggestions for doing that? Because it's just strikingly clear that the data does not represent populations that are most impacted.
Yeah, so thank you for asking that question. One of the things we did upfront with this study, so I lead the study at the national level and the chair for the Recover Adult cohort, so I oversee the entire study across the nation. And we were very, very intentional in making sure that the population that is most affected, Blacks and Brown people, are represented in the study. And that was why we got where we were. We were able to recruit in a way that the demography of the study was representative of the demography of the United States. And so we have enough Black and Brown people now to be able to look at long COVID in white people, long COVID in African Americans and Black, long COVID in Hispanic, long COVID in men, long COVID in women, long COVID in people who live in urban area, long COVID in people who live in rural area, long COVID in young people, long COVID in older people. So it was very intentional. And we, again, the myth that African Americans or Hispanic don't participate in study is not true. If you create an environment that is welcoming for everybody, people want to contribute. People want to offer their service, for study, so that the disease condition that they are interested in can be understood within their population. And we've demonstrated that not only in long COVID, but a number of other HIV study that I do here in Atlanta. The Max-wise combined cohort study, we have a lot of African American women who are retaining the study, who are doing a fabulous job. So the point here is that make an effort to create an environment that is welcoming to everybody, to white, to Black, to brown, to men, to women, to young, to age, to straight, to gay, so that everybody will have opportunity to contribute.
Okay, so we are right at 1 o'clock. So I want to thank Dr. Fontaine once again for your presentation, very informative presentation. And just to remind our participants, our attendees this afternoon, to please complete the evaluation. The link has been posted in the chat. So thank you, and please look out. We will have this lecture posted shortly. So thank you.
Recording in progress.